Answer all of your questions like we normally do. So I'd like to start out by saying thank you all for joining. I'm still really loving doing this. It's a great opportunity to help everybody out. Really open to your questions, and anything you want to ask is fantastic. We've already got someone asking what the best part of being a fertility doctor is. I think helping people is the best part of being a fertility doctor. Making families is a really incredible opportunity. And we definitely get a chance to learn and enjoy from getting to study every time and come back to you guys and talk to you about the answers to your questions and go over all of the various topics that we get to go over. So it's a really amazing opportunity for me. I'm hoping that we're getting to reach out to enough people and that this is turning into something that everybody will enjoy. So in regards to the endometrial receptivity array, this is a test that was designed and formulated in order to determine if the timing of your endometrium is synchronized with your embryo. So when you're trying to get pregnant, especially with IVF or even naturally, your uterus has to be exposed to a certain amount of progesterone for a certain duration in order for the lining to become receptive for the embryo to implant. So everybody's a little bit different. Some people take 4 days, some people take 5 days, some people take 6 days or longer. But the bottom line is that the lining of the uterus has to be ready to accept the embryo when the embryo is implanting. So normally when we're putting in a day 5 embryo with IVF, we'll try and give 5 days of exposure of progesterone to the endometrium, obviously after it's had exposure to estrogen. And then we'll go ahead and we'll put the embryo in on the morning of day 6, which means you've gotten 5 full days of progesterone first. And now you can take your day 5 or even day 6 embryo and put it into that environment with a very high likelihood that it should succeed and have a chance to implant. The endometrial receptivity array is a test that allows the lab to determine if your endometrium, where the embryo is going to land and implant, is actually synchronized with the embryo, and therefore it's received sufficient estrogen and progesterone and is now ready to have the implantation occur. So they refer to this as being receptive. So this test came out around 2012, 2013, I believe. There were some initial studies, preliminary studies, that suggested that this was quite an effective method to correct people who had failed multiple previous implantations with embryos and they had not had success, and no one could figure out why, especially in cases where the embryos had been genetically tested and found to be normal. So in that circumstance, you've got a genetically normal embryo, you've got the lining of the uterus ready, the patient's obviously doing everything they can to succeed, and when they were having recurrent failures, they couldn't understand why. So along came this test. They realized some people are not synchronized, they need less progesterone or more progesterone. And so they then said, well, maybe if we adjust the timing, or what they call the window of implantation, that they could then increase the chances of success and have higher implantation rates. So they did this, and they had a very preliminary study which they suggested and presented at multiple conferences as being very, very effective, and that this was a really great way to go. In particular, they mentioned that in patients that had a very thin endometrium, that this was a successful technique to determine if the endometrium was receptive even when it wasn't thick enough. So normally we're looking for around 8 millimeters of thickness in the endometrium. We want a trilaminar pattern, meaning we want to look for 3 lines. There's a top layer, a middle layer, and a bottom layer. And basically they were saying that even when it's not a triple layer or not 8 millimeters, you can still get success if this test says you're positive. So I used this test quite a bit initially, and it did kind of initially seem like it was working. So we kind of jumped on board and thought this seems like a really logical explanation. The science behind it sounded pretty sound, and I thought that this would probably help many of our patients. And it certainly did. In some cases, we saw that there was some improvement in the success rates. But we started monitoring our progesterone levels for our patients very carefully. And when you start monitoring the progesterone levels after you've started the administration of progesterone, we found that way fewer patients were asynchronous, meaning that the lining of the uterus and the embryo were not synchronized in time. So the company initially claimed that about 1 in 6 patients, or 17.5%, were not synchronous. And then after we started doing the progesterone testing and adjusting, we found that it was pretty much less than 5%. So the test became a lot less relevant once we started doing that. So then I started doing some research into this. And when you look at the studies, and I've got them sitting on a laptop next to me here, but there's about 5 or 6 studies that have looked at the endometrial receptivity array. So if you go on something called PubMed, PubMed, which is run by the National Institute of Health in the United States, you can search for scientific articles that have been peer-reviewed and are published and have been tested and are rigorous and so on. At least some of them are rigorous, or most of them are rigorous. So when you go in there and you type in endometrial receptivity array, about 7 results pop up. And these were ones that had abstracts and some that were randomized controlled trials. When you remove the randomized controlled trial component, you actually end up with a lot more studies. And they've got basic science ones, they've got clinical ones. Each and every one of the studies that has been done, and I reviewed about 5 or 6 all the way from very recent in 2019 back to 2013, absolutely never showed a benefit. So there are multiple studies that have been done testing the endometrial receptivity array, but none of them actually showed a statistically significant benefit. Even when there was a difference in the statistics, meaning the group that did the ERA had a higher percentage of success than the group that did not do the ERA, there still was no statistically significant benefit. And unless there's a statistical significance to the testing, then we don't take the results as demonstrating a benefit. I once upon a time had a discussion with the actual individual that runs the ERA test from the company called iGenomics, and in a sort of personal correspondence via email, that person told me that no, there was evidence for success and referred me to a trial that he had done, which again showed no statistical significance. So I was completely baffled because this made absolutely no sense whatsoever. I had an opportunity to meet with another individual who, for privacy reasons, I'll leave out in terms of name, but is very highly sort of placed both in the infertility world and actually has a very strong affiliation with that company. And they told me that the company itself, iGenomics, had run a randomized controlled trial, which is the best kind of trial you can do to determine if a specific treatment or a specific sort of therapy has a benefit for a patient. And in a randomized controlled trial, what they do is they take half the patients and they randomly assign them to getting the treatment, and in the other half they take the patients randomly and assign them to not getting the treatment, and then they compare the outcomes. So in that trial from iGenomics itself, apparently it did not show a benefit, and it was obviously never published because the company's not going to publish something that showed no benefit. So I've seen it a lot out there when you're on Instagram in particular. All sorts of people say, hey, I'm doing my IVF and then I'm doing my ERA test. The reality is, for the general population, there is no evidence whatsoever that that test is useful. Now, I will say there is one exception that I think makes a little bit of sense, and that exception is when you have a very thin endometrium. So if we have a very thin endometrium, and some people you just can't thicken no matter what you try, there is still some value to doing the test because it will tell you if the patient is receptive or not. I don't know that it's statistically better than not doing the test, and there's no way to confirm that. No one's ever studied that specifically. But I know for a fact myself, I had a patient whose lining just wouldn't get thicker than 3 or 4 millimeters. It was not what we would call a triple layer lining, and we really were puzzled as to what to do, and we tried multiple different approaches, multiple months, everything from Viagra, transdermal, we tried vaginal estrogen, we tried vitamin E, in other patients tried pentoxifylline. There's a lot of different techniques we use, and none of them worked for this particular patient. So we finally said, why don't we try the ERA test for you? We went ahead and tried it, And when we tried that ERA test, it actually said she was receptive. So I said, well, listen, the test is saying you're okay. Let's go ahead and try transferring in this embryo. And it was a very precious embryo for that patient because she didn't have a lot. So we did go ahead and put in that embryo. She got pregnant. She had a baby. Without that ERA test, I would have had a very hard time trying to convince myself that that was a good patient to transfer into. We may have even asked her to look for a surrogate. So I think there are some specific instances where it may be useful to use the ERA test, but in general, ERA testing has no evidence to support its use. The studies that have all been done are very small. The one randomized controlled trial, which supposedly exists, has not been published. And to the best of our knowledge, there is no evidence out there to support its use. So fact or fiction, does ERA help you? No, it does not appear to help you in the general population. And so I don't recommend doing it, on top of the fact that it's now quite expensive. So for those that we did it for, that was a time when we were not doing progesterone testing. And if you're not doing progesterone testing, it may make a difference. But for situations or clinics that are using aggressive progesterone testing and we're monitoring that carefully, it really does not appear that it's a useful test for you, and you probably are not going to get much of a benefit from doing it. So I'm going to take some questions now. I hope that answers this week's Fact or Fiction. We try to spend about the first 10 minutes or so discussing this, and then I'm open to all your questions. So if you have any concerns or questions, feel free to write out to us, and then I'll go through them as fast as I can, and hopefully we can get to all your questions and answers. So I'm just flipping through stuff to make sure I didn't miss anything. And no, I think the first question is... Okay, so someone says, how does endo removal surgery affect fertility? How quickly can one recover from endo surgery, and will this enhance their chances of getting pregnant? So it depends on the severity of your endometriosis, but there is no question that excision of endometriosis has been proven to be effective. So there's actually a Canadian study that we're really proud of called the Endo study, where they did a randomized controlled trial of mild to moderate endometriosis treatment. Everybody got the surgery, but only half actually received treatment. The other half did not get actual treatment as part of the surgery. And when they looked at that study, it did show a statistically significant increase in the rate of pregnancies after the group that received surgery and actually got treatment during the surgery. They've now gone on to do further studies that have demonstrated an improvement as well when they've done meta-analysis of all of those studies. So we do generally tell patients, if you have mild to moderate endo, there is an improvement. It's a bit of a different story if you have very severe endometriosis, because if you have cysts of endometriosis in your ovaries, those cysts themselves can do quite a bit of damage to the ovary. We know that they diminish your AMH level, they diminish your FSH, and they diminish your antral follicle count. Unfortunately, removing the cysts can also do damage to the ovary and do all of those same things. So it's a bit of a damned if you do, damned if you don't situation. As a result of that, if the endometriosis is very severe, there's controversy as to whether or not it's beneficial to remove. A lot of fertility centers and specialists will tell you not to because of the weakening of the ovary, and it's hard to kind of argue with that. At the same time, some places and some individuals, myself included, feel that if you do the surgery in a very careful technique where you are not losing a lot of the ovarian tissue, you're not damaging any of the ovarian tissue, that you should preserve a reasonable degree of ovarian function. You shouldn't have to suffer a lot of damage or loss, and as a result, the success rates should improve. I can tell you very factually myself, because I'm an expert in minimally invasive surgery, I do a lot of endo surgery, and many of the patients that we have operated on have actually gotten pregnant just waiting for their IVF cycle after we've done their surgery. So I strongly support it in the right circumstances. It's not right for every patient, but it's definitely very reasonable to do. So does it help? Yes, it does. Should everyone have it? Probably not. But it's definitely a very reasonable approach to treating patients who have the endometriosis. The second part of that question was, how quickly can you recover? Recovery is, again, very dependent on the severity of the endo. You can certainly get pregnant right away, but in terms of actual pain recovery, symptoms of the surgery, gas trapping, your bowel function, bladder function, Most people will feel fairly well within about a week to 2 weeks. If you have much more extensive surgery, it may take longer. Most of the time, it's about 6 weeks before you're fully recovered and feel yourself again. So it can take a little while. Okay, I'll take a question that says, I heard that if you burn the endo off, it comes back really quick versus cutting it out and having a great success rate of feeling relief for an extended period of time. Do you offer both burning and cutting? And I can't read the rest of that comment, but anyways. So the reality is there is actually a good study that has compared what's called excision versus ablation. So excision is removing the endo, and cautery or ablation is burning the endo. And with the exception of a clinically insignificant difference in pain, there is no difference in the outcomes of burning versus excising endo. So they've actually studied that. Again, I've seen on Instagram and Facebook and so on, people that absolutely demand that they have excision versus ablation. The data just isn't there to support that assertion. So you can have an ablation or you can have excision. Certainly for myself, if the lesions are deep and they're kind of penetrating through the peritoneum into the tissue underneath it, excision seems to be more appropriate. If it's just a surface lesion and you can get good effect by just burning the lesion, then there's no need to try and excise. It also very much depends on where the endometriosis is. There are some lesions that you can't just burn because they're very near nerves or vessels, and likewise there are some you can't excise because they're very close to nerves and vessels. So it all depends on the specifics of the situation. It's not a circumstance where one sort of treatment fits all. And I've said this before and I'll say it again, infertility and medicine in general is never a cookie cutter approach to things. One size does not fit all. It always needs to be individualized. And if you're not getting individualized care for your fertility, then you're not getting adequate care and you need to get a second opinion. So hopefully that answers that question. The follow-up to that, I guess, is just the part that says, do you get extended relief or extended period of time from the excision? No, you don't. Endo will come back typically in 6 months to a year. And the data looking at how long your pregnancy improves or pregnancy rates improve for is 6 months to a year. So endo generally will come right back. It's not going to stay away just because you had it excised versus ablated. So someone has asked, I'm curious about cycle day 1 for upcoming monitoring. I normally spot for quite a few days and then we'll get a little heavier for a few days, then spot some more. So how do I determine what cycle day 1 is? That's a great question. So it can be difficult, and sometimes we kind of have to use a combination of hormones and ultrasound to figure it out. But generally speaking, we consider cycle day 1 the first day when you actually need to use a pad or a tampon and you find that the flow is heavy. So typically that's what we would go with. You could certainly be aggressive and get very frequent monitoring, like daily monitoring of your FSH, your LH levels, check your estradiol levels and your lining of your uterus, and that might give you some sort of experience or knowledge with what's going on to determine what cycle day you are. But generally speaking, cycle day 1 is the first day where you need a pad or a tampon, and if it's after 6 p.m., we usually tell you to consider it the next day. Someone's asking again about endo. Would you recommend treating the endo before trying to conceive? We're trying to conceive first and then dealing with the endo. So it's completely reasonable to try and conceive first if you have mild to moderate endo, or even if you have severe endo. And if it's not working, then to get the endo treated. It's a little bit different if you're going to undergo fertility therapy like IVF, because IVF with endo has a very special protocol that's required. You need to do your egg retrieval, freeze all of your embryos because your endometriosis will be maximally overcharged when you are at the end of your egg retrieval, like right at the peak when you're doing your egg retrieval. Your estrogen levels are as high as they're going to get. And so that's the worst time to consider doing an embryo transfer because your endometriosis is fully supercharged and being fed by all of that estrogen. So we freeze all your embryos instead. You should then go on both a GnRH agonist like Lupron or Trelstar or one of the decapeptyls. And then you basically need to use Lupron with letrozole. So a recent randomized controlled trial showed that if you used both, for a minimum of 3 months, that the success rate greatly improved. And so we do recommend you use a Lupron and letrozole protocol. And then after a minimum of 3 months, you can transfer in those frozen embryos with a very good success rate. So that's the approach to doing it if you're doing IVF. If you're not doing IVF, you can pre-treat for several months with, again, a GnRH agonist. There's an oral antagonist now called Orilissa. There's a great drug called Bizan. All of these are reasonable for suppression of the endo. And then you can try to get pregnant for a few months, or you could do surgery first and then try to conceive. There are multiple options, and it really depends on your goals, your timeline, how aggressive you want to be. If a lot of miscarriages happen because of chromosomal genetic disorders, does taking estrogen and progesterone prevent even those miscarriages? No, not at all. So if you have a genetically abnormal embryo, which is usually the case somewhere between 60 to 80% of the time when you've had a miscarriage, then the likelihood that the embryo will miscarry is very high, and taking estrogen or progesterone may delay the miscarriage, but it is extremely unlikely that it will prevent it. If your embryo is not programmed to develop and continue beyond a certain gestational stage, it is unlikely any kind of treatment that you do will alter that. There may be a few rare exceptions, but I don't think that anyone would support the notion that the hormones are going to support a genetically incompetent or abnormal pregnancy and continue that when it's not supposed to happen or not supposed to continue. I'm just going to deal with something right there. Okay, so next question. Is embryo glue necessary, and do I know anything about it? Yeah, actually, that's a great question. So embryo glue is a combination of hyaluronic acid and a couple of other things that I believe are proprietary that they throw in there. The studies on embryo glue are, again, fairly controversial. There are some studies that say it works. There are some that say it doesn't. In general, if you talk to embryologists, they say it doesn't have an impact. It's not very expensive, so it's not an unreasonable consideration, but no one has ever been able to categorically demonstrate that this is going to be a benefit. We don't typically use it. There was a recent study from actually an Iranian study that demonstrated when they combined all of the other previous studies and did a meta-analysis on the use of HCG around the time of embryo implantation, that this actually did improve the success rates, and it was significant in the meta-analysis. The individual trials are quite controversial. Some show a benefit, some do not. A lot of it seems to have to do with the timing of the HCG administration. Some people are doing it days before, some people are doing it right before. I kind of looked at that study. I was impressed by the results. And so I said, for the patients who have previously had failures or have only one embryo, we can start doing these HCG washes. It's very much like doing an insemination or an embryo transfer, but you actually just put in a tiny amount, 500 units of HCG first, and then you transfer in the embryo. That actual study suggested that you should do it 15 minutes before, and we have been doing that. We are seeing a bit of an uptick in the number of pregnancies that we're getting, but there are some miscarriages that are occurring as well. So the question is, and this has been brought up by other REI specialists as well, are you making the endometrium with all these sort of tricks that we use really, really receptive for embryos that are not supposed to implant? There's probably some biological mechanism in place to not allow suboptimal embryos to implant. And if we overcome those mechanisms, there may be instances where an embryo that's not supposed to implant is implanting. Obviously, those are going to be at a much higher risk of miscarriage, so they may be the ones you don't necessarily want implanting. So we don't use the glue. I have started using the HCG, but this is very recent. We've only been doing it for a few months, and we kind of have to see what happens. It's harmless. I'm not charging my patients for it, so we'll see how things go, and I'll definitely get back to you guys with more information about that. Okay, a PCOS question. Unfortunately, my PCOS was not discovered until trying to conceive. Since this can be hereditary, what can I do for my teen daughter as she approaches to approaches puberty to avoid all the horrible symptoms. Okay, so if you are thin PCOS, unfortunately, there's not a whole lot you can do. Vitamin supplements, inositol, myo-inositol, N-acetylcysteine, or NAC for short. A lot of the natural approaches are actually quite reasonable. We talked about some of those last time with the amazing Dr. Jennifer Strong, the naturopath who was on with us. But when you're talking about the patients that are in the non-thin category, they sort of experience the more normal PCOS where typically weight is a bit of an issue. Those patients really need to monitor diet and weight. The best way to do that is eat multiple times per day. So a lot of these patients tend to try and starve themselves. And that is the worst thing you can do because your insulin levels start to rise and everything you take in you begin to store. So what you want to do is actually drive your insulin levels down, and the best way to drive your insulin levels down is to eat multiple times. So you want breakfast, snack, lunch, snack, dinner. So 5 meals a day, and those will drive down your insulin levels, which stops some of the tendency to store everything and can help you burn off calories easier. The other part is it is critical to exercise. It is not sufficient to just diet properly or have a healthy diet. You must exercise because PCOS women do have difficulties with their metabolism, with insulin resistance frequently, and exercise is a huge component of burning off some of the excess calories and driving down the insulin levels again. The more muscle mass you generate, the higher the chances that you're going to burn off some of your calories just maintaining your muscle mass. So don't go get on a treadmill for an hour. That's not going to help. You actually want to do about 60, 70%, maybe even 80% muscle building and only about 20% cardio. You also want to minimize carb exposure. So get rid of everything in the house that's full of carbohydrates, sweets, chips, pop, drinks with lots of sugar in it. Eat healthy, live healthy, lots of exercise, lots of good nutrition. Okay, so quick Facebook question, which is how would you know when to use the HCG, just to follow up on what we talked about a moment ago. So if you are trying to determine when to use the HCG, the answer is I typically will use it when the patients have had a previous failure. If you've never had a previous failure before, it's probably not a huge issue. You can go ahead and try normally. But if you have had previous failures, HCG wash into the uterus prior to an embryo transfer is completely reasonable to consider, and that's something that I would support. Usual, I've heard both. Okay, so we talked about this a little bit last week. Last week I did fact or fiction, it was 2 weeks ago, whether or not resting after an insemination was helpful. And after an embryo transfer, it actually has never been proven to be helpful. So there's actually a really good study out of California which demonstrated that the patients that got up and returned to work had a higher success rate than the patients that rested at home. The theory behind this is it probably has a lot more to do with whether or not you get stressed than it has to do at all with your activity level or what's happening in terms of your motion or embryo motion or any kind of dynamics in that sense. So if you find that going back to work, keeping your mind occupied with your normal activities is going to help you sort of relax and be less stressed, then go back to work. And if you think that resting at home and being away from the hustle and bustle of your work environment, especially if you're in a more stressful work environment, is going to be beneficial, then for sure that's what you should do. There's no sort of 100% guarantee that one approach is better than another. Again, there's no data that supports rest after an embryo transfer. But like I said, if you're less stressed by resting, then for sure go ahead and rest. And if you are less stressed by being in your work environment, being around the people you know and you recognize and keeping your mind occupied otherwise, as long as you're not in a situation where you're really exposed to chemicals or extremes of heat or temperatures, you're not around a lot of strain and there's no sort of very heavy lifting involved, it's probably perfectly reasonable to return to work. Okay, there's a Facebook question. Hello, doctor. I went to the hospital 2 months ago and the doctor told me that because of the symptoms I have every month, I could suffer from endometriosis, but they did not do any in-depth study on, and I hate trying to do the see more. How do you do the see more? Right on that one right there. There we go. I could suffer from endometriosis, but they did not do any in-depth study, only ultrasound. Okay, so how do you diagnose endometriosis? That's a really easy question. There is only one way to diagnose endometriosis, and that's with surgery. Even with surgery, you need a biopsy to confirm that it's actually endometriosis. So you have to have surgery in order to determine it. There are certainly women that have numerous signs and symptoms that appear to be very consistent. So it's called the 3 Ds. Dyspareunia, which means you've got pain with intercourse. Dysmenorrhea, which means that you have pain with your menstruation or menses. And deep pelvic pain, which just means you've got deep pelvic pain. So if you have any of those, or a combination of those, it's very likely that endometriosis is a possibility. You can see cysts of endometriosis on ultrasound, and if you've got a good ultrasonographer or a good physician that reads those ultrasounds, I do a lot of my own myself, I can distinguish an endometrioma with a very high degree of certainty on ultrasound. But if it's not an actual cyst of endometriosis, it is extraordinarily difficult to tell if you have small lesions. If you watch any of our posts on endo, there's a YouTube video we have on Victory Reproductive Care on YouTube, and there's an Instagram post we have as well on endometriosis surgery. You can see that sometimes they're just tiny little specks. That's not going to show up on any kind of imaging, whether it's CT, MRI, or ultrasound. They're too small and well beyond the diagnostic capabilities of any current imaging system we have. So ultrasound is not enough. You need surgery. Now, we don't operate on everybody with endo, and if you're not trying to conceive, it's actually quite reasonable to figure out if it's potentially endo by simply taking some type of endo-related medication and seeing if the pain settles down. If your pain gets better when you're on the pill or Oralisa or Vizan or Lupron or any of the medications that we use, then it's certainly a possibility that endo is there. It's, again, no guarantee, but it's a reasonable test, and if you're not trying to conceive at the time, you can certainly use those medications to control the pain. They will likely limit the growth of the endometriosis, and that's a very, very reasonable, rational approach until you get to the point where you do want to conceive. Okay, last week I went again because the pain was unbearable, and a different doctor told me that there was no reason to have pain because on the new ultrasound everything looked in order. Is laparoscopy needed? Yeah, so that's the follow-up to that same question, and the answer is yes, you need to do laparoscopy. Is it necessary to act immediately? No. Endometriosis is rarely an emergency unless it's involving bowel or invading into something like lung or brain. Aside from that, no, it is not an emergency. You can take your time and figure this out and make a choice that's right for you. Okay, so hello, Dr. Victory. We love you. I love you back. Thank you, guys. Okay, so my question is, if you've had a forceps delivery for your firstborn, is it contraindicated for subsequent pregnancies? No, it's not contraindicated. Contraindications occur if you've had a 4th degree tear. So there are different degrees of tears. I'm going to try and do this with my fingers. So if this is the vagina and your rectum is kind of down here, if you tear just in the vagina, that's a 1st degree tear. If you tear through the muscle here, called the bulbal cavernosus, that's a 2nd degree tear. If you get to the top of the rectum, that's a 3rd degree. And if you actually tear into your rectum, that's a 4th degree tear. So a 4th degree tear, you should not be delivering vaginally again, let alone forceps. Too much damage to the anal sphincter can cause you to lose continence, and that means you may not be able to control your gas or your bowel movements. So that is contraindicated. But a 3rd degree tear is a little more controversial. We frequently will allow patients to deliver vaginally if they've had a 3rd degree. If you look at some of the literature, they actually support offering cesarean sections electively to those patients as well. And I usually have a discussion with my patients. I always want it to be your choice. With anything reproductive, it should be you guys that are in control. And that's kind of the language we use with you. So you're in control. It's your choice. You have to decide what's right for you. I'm not in any position to decide what's right for everybody. I want to give you the information that you need to make a decision. I want to give you the choices you need to have so you know what options are available to you, but you've got to ultimately decide. One thing you can do, which might minimize your risk, is get an ultrasound for the growth of the infant around 36 weeks. we can use that to kind of project how big the baby is going to be. And clearly, if you're going to have a huge baby, maybe it's not a great idea to have another vaginal delivery. Infants do tend to get bigger every time. So if you're thinking you're going to have a very large infant and you're going to have another forceps delivery, maybe that's not the best way to go necessarily for you. But again, it depends on your priorities and your stomach for taking risk, right? If you're willing to take the risk, then it's definitely something your obstetrician needs to discuss with you and consider. Okay, so back to Instagram. I did IUI for first pregnancy. If I require it for my next, will I have to go through all the testing with your clinic again? Is the wait time the same as any new referral? That's a great question. So we do try to get in return patients as quickly as we possibly can. And we are working on introducing a new physician into our clinic to absorb some of the wait time. So I apologize to all of those of you who are waiting. Believe me, it's not for lack of working. I was here on Saturday seeing consults. We do our best to try and accommodate as much as we can. But it's difficult to see, everybody with the waits that we have and the number of patients that want to see us. I guess it's the curse of trying to do your best for everybody. The problem is everybody wants to come. So we're thrilled to have you guys join us and see us here. But unfortunately, there is a wait associated with it. So you have my deepest sympathies and my apologies for making you wait. The testing does need to be renewed if it's been more than a year because things can change, especially things like polyps, fibroids in your uterus. There can be changes in your hormones, especially in thyroid conditions. So yeah, we do recheck everything, but we kind of get you in really quickly, make sure nothing drastic has changed. Usually that initial appointment is quite quick because you already know what needs to be done. We have the paperwork ready for you before you arrive. We hand it to you. You get started. It takes about a month to do the testing, maybe 6 weeks. And then we try and get you in as quickly as we can to review the results, go over them and get you into whatever treatment you want to do. So we do get you in fairly quickly and we move forward from there. There is an awesome question I would love to take from Facebook. So can interstitial cystitis be confused for endo in the bladder or do they appear differently? Okay, so the symptoms can frequently be confused. So interstitial cystitis is an inflammatory condition of the bladder, and it causes severe bladder-related pain. It can also cause pain with intercourse, and although there shouldn't be menstrual-related symptoms, sometimes there are. In terms of what it looks like, it does not look like endo in the bladder. Endo in the bladder, which is actually fairly rare, looks like endo everywhere else. It's like a purple or a blue or a black or a red lesion. And if it's old endo, it might be white. Interstitial cystitis, you really kind of don't have a specific typical look for. Sometimes you get these very sort of squirrely or spiral vessels inside the bladder, blood vessels. And what we normally do is we inflate or insufflate the bladder with fluid, and then you desufflate it. And when you do that, you start seeing all these tiny little hemorrhages from those blood vessels. And that is thought to be a sign of interstitial cystitis. So inside the bladder, where you actually try and find the IC, it does not look the same at all. It is fairly easy to distinguish. And a urologist or a gynecologist with experience doing cystoscopy should be able to distinguish easily between the two. Thanks for caring and your compassion regarding fertility. Glad you've helped us. God bless you. I'm glad I got a chance to help. So thank you for that. If you had a C-section for your first and told your pelvic bone is small, how likely is it to have a second C-section? Is there a way of telling this beforehand? If you have a narrow pelvis and you had your C-section because you tried to labor but you couldn't deliver the infant vaginally, then the success rate doing what's called a trial of labor after cesarean or a TOLAC, we used to refer to it as a VBAC, which was a vaginal birth after cesarean, is definitely lower. So TOLAC rates can be as high as 70% in the right circumstances, and they can be as low as 0% in the wrong circumstances. So definitely, if your pelvis was very narrow and you had a large baby, the chances are fairly good that you may fail again. Again, that's a really easy one to determine. Get an ultrasound done at 36 weeks, see how big the baby is, and then make an informed decision. there is no harm in trying. So laboring a baby to see if you can deliver the infant vaginally is completely safe. And in some regards, it's actually safer because it helps the baby move lower down into the pelvis, which actually makes the cesarean section easier. If they break your water, it can actually help drain the fluid from the baby's lungs so they don't have as much breathing difficulty when they come out, which what we call cold sections where there's no labor actually do have a higher incidence of having fluid stay on the baby's lungs. So delivering the baby, or at least attempting to deliver the baby vaginally, is beneficial, but do it if you want to, and only if the circumstances are right for you. It's totally reasonable to try. There's, generally speaking, no harm in trying, as long as you had a sideways incision on your uterus when they did the actual cut, and they did a 2-layer closure. So you've got the two sides of the incision. You got to bring them together, fold them in, and sew them again together at the top. So one is here and the other one is there. You got to put them both together to thicken the lining and reinforce the wall of the uterus. If you've had a single layer closure, which happens sometimes in other countries, sometimes even in the US, that is not safe, likely to deliver by a trial of labor after cesarean. And for sure, if you had to have a modified version of a sideways incision, meaning you had a J incision, a T, an inverted T, or a what's called a classical incision, which is straight up and down on the uterus, none of those are safe, so do not try and labor again. Okay, let me see if I've missed anything on Insta. Does eating soy products affect fertility? Supposedly it's beneficial. We talked about that last week with Dr. Jennifer Strong. Soy products have never been shown to be detrimental, and they actually may be beneficial. So no, there's no reason why you can't use soy products. Go for it if you like them. I'm actually trying to become vegetarian, so I'm probably going to be having a bit more soy myself. I watched that very interesting program called The Game Changers on Netflix, which is about a UFC fighter who gets injured and wants to heal himself and switches to a plant-based diet. And after watching that, it's actually very convincing that we should all become vegetarian. So I am a terrible vegetarian, but I am trying. So soy is perfectly fine. Go for it. When does a biopsy of a cervix detect? How can it be treated? I'm sorry, I don't understand that question, but I think if you mean if there's cervical disease, how can it be treated? So this is non-fertility related, but just really quick. If you have human papilloma virus, which about 80% of people carry, then you are at risk for having cervical disease. If you do a pap smear, it should be detected on your pap smear. If the pap smear turns up positive for various diagnoses, and your gynecologist can explain these to you, then you need to take the next step, which is called colposcopy, or something called HPV testing, which is testing for that human papilloma virus. If you do the colposcopy, they will biopsy the cervix and know if there's a problem, and then further treatment can be determined based on what that problem is. In general, if you have high-grade disease, that's considered true precancer, and it should be surgically treated, either frozen, removed, ablated, whatever the technique you want to use is. If you don't have a high-grade disease, you just have low-grade disease, no treatment is necessary unless it's very persistent and you can't get rid of it. Everybody should be getting vaccinated. The vaccine is safe. It is very beneficial. And it is the first time in history that we can actually prevent cancer simply by using a vaccine. So regardless of your religious beliefs, your ethical beliefs, that vaccine is very safe. No harm has ever been shown from that vaccine, and it's very, very highly recommended. Okay, can implantation happen as late as 10 days post an FET? No, not generally speaking. So the embryo is really ripe for implantation around day 5, day 6, depending on the stage of the embryo itself. So the embryo should adhere to the uterus within the first 24 hours after implantation has occurred, transfer has occurred. So if you do a day 5 transfer, your embryo should be stuck. If it's 10 days, I guess anything is possible, but I would think that that would be quite unlikely. And so it's probably a lot harder to achieve an implantation 10 days after a frozen embryo transfer. Possible, yes, but it would be very, very unusual. Want to have twins? Possible. Is it possible for us to have, make you have twins? There's no way to guarantee twins, but there is definitely ways to increase the chances. However, I never recommend anybody try to have twins unless your age is substantially higher and you want what people refer to as one and done, where you just want one pregnancy and then you don't want to have to get pregnant again because your age is sort of in the mid or even late 40s. For all other patients, all risks of pregnancy, hypertension, diabetes, preeclampsia, early delivery, preterm labor, hospitalization, bleeding, I could go on here forever and ever and ever, preterm rupture of membranes, all risks of pregnancy are increased when you have twins. On top of that, it is an 80% divorce rate. So we do not recommend to anybody that they try to have twins unless they really, really want to have twins. I don't believe it's something people should try and do. I think people should definitely consider doing it if the circumstances necessitate it, but that is very, very rare. Generally speaking, it's much healthier for you. It's much healthier for your infant, and it's definitely much healthier for you guys as couples to just do it one at a time. That doesn't mean that if you have a twin pregnancy that you have to be terrified or petrified. We take very, very good care of our twins, definitely monitor you guys like a hawk. Many of you who are my patients know that I take care of my own fertility patients for their obstetrical care. And so we watch you very, very carefully. And so we can manage most of the complications, but it's definitely safer to have them one at a time than it is to have them two at a time. Okay, can ureaplasma prevent an embryo from implanting through IVF, and can it cause miscarriage? Oh, that's a fabulous question. Thank you for asking that. So in the animal research, ureaplasma and mycoplasma have been shown to cause problems with implantation and definitely recurrent pregnancy loss. In human studies, neither of those have ever been proven, but we do test for it for patients that have recurrent pregnancy loss, and we treat it when we find it. It actually can be quite difficult to treat. I've had several patients where we had to send them to the infectious disease specialist just because I couldn't get the bacteria to be eradicated. It would not go away despite multiple various courses of antibiotics. So it can be hard to eradicate, it can be hard to treat, but we do try for sure. There is a lot of research these days going into determining what bacteria in the vagina and what bacteria in the uterus itself are either necessary or detrimental to embryos being implanted. And there is a lot of evidence coming out that what they call the microbiome, which is the composition of the bacteria that are in that environment, actually has a huge impact on your success rate. So that there's a lot of work going into that. The problem is we don't know how to alter the microbiome of the uterus. There was an interesting presentation from that same iGenomics company that does the ERA test I talked about at the start of this Fact or Fiction session. And they said that they can tell us from an endometrial biopsy whether the lining is normal or not. Well, that's great. I mean, that's awesome. We can figure out if the right proportion of bacteria are there, and I think that's fantastic. The problem is there is no way to alter it. And when I asked them what you're supposed to do, they said, well, put a tampon in the vagina that's soaked with lactobacillus. But at the start of that same presentation, they themselves told us that what's in the vagina is not reflective of what's in the uterus. So putting that tampon in there has no expectation of improvement. So yes, you should get checked for the ureaplasma, mycoplasma. We probably are moving towards doing more and more testing of the microenvironment and microbiome in the uterus and the vagina, but we really do not have a good understanding of what to do with those issues when we detect them or how to treat them. So it's hard to know what to do for those. Okay. Did you just say non-thin category? Yes, I said non-thin category. I always choose my words as carefully as I possibly can. And I know you, don't be a troublemaker. Okay, I want to answer this. Am I an RE? Yes. So Just for those of you that aren't familiar with the terminology, a RE or an REI stands for Reproductive Endocrinology and Infertility Specialist. So I am a Canadian trained and board certified obstetrician gynecologist with a 3-year American Board of Obstetrics and Gynecology subspecialty fellowship in reproductive endocrinology and infertility. I am board certified in Canada and in the US for OBGYN and infertility. So hopefully that answers that question. I totally take questions, so feel free to ask the questions. How important are thyroid levels for infertility? Thyroid levels are critical for infertility. Not just your thyroid levels, but your antibody levels as well. And there was just a recent study, and we did a post on that, I think it was about a month and a half ago, on Instagram. So you can find it there, rahivictory.md. And I talked about the impact of thyroid antibodies and thyroid levels in that article. In general, you want your TSH, your thyroid stimulating hormone, to be less than 2.5 before you try and conceive. And we want your antibody levels to be negligible or as close to negligible as possible. It is difficult in some patients to achieve that, but we definitely want to try. Okay. Here we go. For recurrent miscarriage, one of the screenings is a biopsy of the cervix. Was just wondering what it can tell you, but I think you answered that. Oh, okay, sorry. So I misunderstood. I thought we were talking about HPV. So the answer to that is it's not a cervical biopsy. It's an endometrial biopsy. That's a biopsy of the lining of the uterus. And what we're actually looking for is inflammation or infection inside the uterus that is active. So not just the balance of the bacteria, which is the microbiome, but is there an active infection? Is there inflammation in the lining? There is no question that if you have inflammation or infection in the uterus, you will have a higher rate of miscarriage and recurrent pregnancy loss. And we do treat many of those with antibiotics in the hopes that the uterus will reset itself. But again, there's no proof that this stuff works, and no one has yet done an adequate study to determine if simply treating with antibiotics is the solution. It does seem to be beneficial, but that's just me telling you my experience. We don't have a scientific study to confirm that. Okay, what should I ask my doctor before pursuing embryo adoption? I'm 26 with DOR, IVF doesn't seem like a great chance. Oh, well, first of all, I'm sorry you're experiencing DOR at 26. My heart goes out to you. That's a really, really difficult thing to deal with. So DOR, for those of you that don't know, is diminished ovarian reserve. So IVF does have a chance, and at 26 it may be reasonable, but it depends on how significant the diminishment in your ovarian reserve is. We do a lot of natural cycle IVF where we just try and use one egg that you normally produce if you're still having a period, and we can grab that egg, turn it into an embryo, and re-implant that inside you without even needing to freeze it or do a freeze-all protocol. So you don't always have to turn to a maximal stim IVF protocol or trying to make many eggs. Sometimes it just takes one, and some of my favorite IVF success stories are those ones where we did it with just one egg and natural cycle IVF. The amount of medications you need to take is minimal. The stimulation is really easy. It's a shorter period of time usually, and we typically get fantastic embryo quality. Having said that, if you are already menopausal or you feel based on the discussion with your doctor that the chances are very low, what you want to know about embryo adoption, basically as long as you can produce a healthy endometrium, there is no reason why you can't do embryo adoption. It can be difficult to do embryo adoption, and I have to say I'm very disappointed in many centers that charge an exorbitant fee for embryo adoption. We typically do not charge that much, and I know once we set up our Windsor program, we definitely will not be charging that much for embryo adoption. God bless all the parents out there that have allowed us to provide this service to many families and patients. We have lots of couples that have had tremendous families as a result of other families helping them. So I think it's definitely very simple. You just need to make sure that your lining responds. And as long as your lining responds, there's no reason why you can't do it. Things you would want to know would be the age of the parents that created the embryo, in particular the female. You would want to know the quality of the embryo. Were they done at the 3-day stage or the 5-day blastocyst stage? And you would want to know things like the racial background, if that was important to you. For some people it isn't, then that's wonderful. You'd want to know about the health history of those patients as well. Is there a family history of cancer, diabetes, heart disease, and so on? Okay, Facebook. What's the risk of having more miscarriages after having multiple miscarriages followed by one successful pregnancy? That's a good question. I'm not aware of any specific data in that typical or that atypical paradigm or process, but certainly if you've had multiple miscarriages before, you are at a higher risk of having more miscarriages. But thank God, if you've had a successful pregnancy, it bodes very well for your ability to have more. I can tell you that I have one patient who told me that she had had 26 miscarriages in total, but we were able to help her have several children in between all of those. And so even when the story looks like it's absolutely nightmarish, there is still opportunity to succeed, and never give up hope. Recurrent pregnancy loss is brutal. It's terrible. It is cruel and unfair. But typically speaking, we can be very successful in helping patients. And I'm really proud of the fact that we have actually rarely failed at our clinic. And we really try and do everything humanly possible to help our patients succeed. Okay. Would you suggest going on antibiotics before embryo transfer if you've had a history of endometritis? I wouldn't just suggest it. I'd say it's mandatory. So for sure, if you've had endometritis, you want to be on antibiotics. That seems like a very logical thing to do. And we actually give all of our patients antibiotics. So I think that's a very reasonable approach for many centers and fertility specialists. Okay, how soon after FET implantation is it safe to travel via airplane? So someone asked this previously, and I'll just quickly answer again. There are air pressure changes if you're getting on a flight that's kind of pressurized, so you're going fairly high up in the air. And because of that, we don't really recommend that you get on any of those planes until you've definitely seen a heartbeat, and probably even till 3 months. Certainly in the early stages, those air pressure changes may, and I emphasize may, result in oxygenation changes to the embryo. And the last thing you want to be doing is altering the oxygenation of an embryo. So I would recommend you avoid that. For those of you that have gone, sort of planned trips or have tickets already purchased, please use your insurance. For those of you that can't get out of it on your insurance, I am sure friends, family, or any of my office staff would be more than happy to take your place. So just let us know how we can help. Sometimes it's a letter from the physician. Sometimes it's, just talking to the airline or talking to your travel agent and making alternative arrangements. If you've had a history of miscarriages at 12 plus weeks, would you recommend starting progesterone before trying to conceive? Okay, so never ended unexpectedly. That's weird. Okay, I'm going to stay on Facebook for a few more seconds here. We're winding down to 8 o'clock. So has there been any conversation about getting Canada on the global cord blood registry? I'm still live, it says. Okay, well, we're live on Facebook, just not live on Instagram. It shut off for some reason. So Canada does cord blood, and the two biggest companies right now are Inception and Create. And one of the other companies that was quite large actually got purchased by Inception. So if you're using Cells for Life, you're actually using Inception, whether you know it or not. So they are privatized and you have to pay for it. But the reality is that I'm not sure if we're on a global cord blood registry. I will ask for you and I will let you know. Hopefully we're back on Instagram. I think we're kind of near the 8 o'clock mark, but if anybody had some questions, I think we lost some. If you want to toss on your questions real quick, I will jump back on and answer them. I know I missed a couple there trying to just restart Instagram, so sorry about that, guys. I think Instagram cuts you out after an hour if you're on live, so we've been chatting for an hour there. if anyone has any other questions, happy to address them. If not, I'll give it about 5 minutes for people to jump back on, and maybe 10 minutes to jump back on. Oh, here we go. And then we'll go from there. When am I starting IVF in Windsor? The lab is being built. The microscope is arriving on the 18th. We've already got one of our incubators, and another one is here as well. Our final stages are right there, so we should be up and running hopefully by January. We will need the college to come in and approve us to get started with retrievals, so hopefully January, February we're going to be starting. And will existing embryos be transferred? Ideally, no. I'm certainly not going to stop anybody from transferring their embryos, and I am going to be very respectful of everyone's wishes, of course. But I'm not sure that transferring embryos on a 4-hour drive is a great idea, guys. So I think it's always better to have your embryos thawed and transferred where you made them. So I think that's probably the best thing to do. Leave your embryos where you made them. The embryologist has a special skill set. They have their own techniques. It probably makes a lot more sense to leave them where you made them. Okay. What is done differently at embryo transfer for someone who has had multiple miscarriages? That's a good question. No one's ever asked that. Nothing at embryo transfer specifically. Every embryo transfer really should be done the same way. You want really good visualization. You want it to be very comfortable. You don't want to hit the top of the uterus. Generally speaking, almost every article out there says that the embryo should be implanted somewhere in the upper third of the uterus, and typically somewhere around 1 to 1.5 centimeters away from the fundus. So there's no difference there, but there are adjunct therapies that some people use and other people swear don't work. The data on most of the treatments and adjuncts that are out there suggest most of them have not been proven to have a benefit. Things like heparin, aspirin, intralipids, IVIG. There's a study on Humira and IVIG, which suggested that after 6 previous recurrent failed implantations, so not miscarriages, but failed implantations, they got an 80% pregnancy rate. An 80% pregnancy rate is hard to achieve under the best of circumstances, let alone in people that have failed 6 previous transfers. So that data was very suspect. So there's nothing we do differently, but we certainly talk to patients about all of the options that are available to them. There are some adjunct treatments we use. I'm kind of a believer in them. I go through the results with patients. I talk to them about the risks and benefits. If there are costs, we talk to you about that as well. And I give you the opportunity to make an informed choice. And that's really what every doctor should be doing. Give you the information, like I said earlier. Make sure you understand all of the options that you have. And then it's really up to you guys to decide what you want to do. So hopefully that answers that question. Okay. And I think we had another question here. Yes, I will still transfer at Nahal. So if you have your embryos at Nahal, I will still do your embryo transfers there. Okay. I think I will take the last question. Well, first the comment. We are so lucky to have you in Windsor. Thank you for this Monday night Q&A. Thank you. I love the fact that you guys are here listening, and I appreciate the time investment into this. Spread the word. Like I said, I love doing this, so let everyone know. The more people we get on board, the better this will be. Last question is, so if we need to do ICSI, does that need to be done in Toronto? Oh no, we'll have full ICSI set up here. Don't worry, guys. This will be a full-fledged IVF center. Everything will be able to be done here. Embryo transfers, sperm freezing, egg freezing, embryo freezing, the egg retrievals, ICSI, everything possible, the HCG washes. We've really set this up to be a top flight center. I've got the newest and greatest of all the equipment. The lab is beautiful. The office is really lovely. And I have put together an amazing team of people to help you all. So hopefully that's all the steps we need. And like I said, we have our naturopath. We've assembled an incredible resource set for patients with difficulty in terms of emotional issues and in terms of psychological strain. And we also are bringing on board some additional fertility docs so I can get to help you guys out faster and more efficiently. So hopefully that'll help. Okay, guys, so it's 8:06. Hopefully that's answered enough questions for this week. If you guys have topics you want me to do a Q&A on, or you have something that's a little more controversial you want me to look up, don't hesitate. Let me know what those issues are. You can message us on Facebook, on Instagram. I'm happy to try and spend some time looking them up and be ready for your questions and answers. Additionally, if you have anything you want me to do for the fact or fiction, it actually takes me a bit of time to pick something that's got just enough controversy to make it interesting for you guys. So let me know if there's something you want me to do. I will be more than happy to pop it up there and use that for next week. So have a great night. Thanks again to all of you for watching. Thanks to Tarek Ibrahim from Ibrahim Strategies Group for doing our multimedia stuff. And hopefully one of these days Instagram will stop canceling out on us. Have a great night, guys. Enjoyed talking with you. Bye now. Are we off of YouTube? Are we still on? Bye.